Não precisa. Bom dia a todos. Queria agradecer a presença, a participação, tanto presencial quanto remota, de vocês nessa conferência que o professor 𝗏𝗏 vai apresentar para nós. O professor 𝗏𝗏 é o criador do Kit Save Lives no mundo e também uma sumidade internacional na área de ressuscitação. O professor tem um currículo extensíssimo, não consigo nem falar parte dele, e professor titular de Anestesiologia da Universidade de Colônia, na Alemanha, e ele está aqui para nos falar sobre ressuscitação e cuidado pós-ressuscitação. É um prazer imenso e acredito que vocês vão poder aproveitar muito. Eu não sei se vocês vão precisar de tradução, a gente poderia, porque se for passar slide por slide, vai ficar muito complexo, né? Eu acho que quando vocês não entenderem, por favor, vocês puderem levantar a mão e perguntas à vontade, tá? Eu vou passar, então, agradecer novamente ao professor pela presença. I'd like to thank you very, very much for your presence and for your conference here at the Medical School of the University of São Paulo. Thank you very much.
Thank you very much, Naomi. We need an applause for Naomi. So, thank you very much for being here, and thank you very much for inviting me. It's a great honor and a great pleasure to be here with you today in this beautiful building with a beautiful garden and with a beautiful faculty and very nice students, isn't it? So I'm coming from Cologne in Germany. Have you ever been in Germany? Yes, Naomi was there. Anyone else being in Germany? Where have you been? Okay, very good. And Cologne, I'm from Cologne, the big church. It is 8 degrees Celsius in Germany right now, so I'm happy that I be here, but I have to fly out again tonight back in winter time, I would say. Naomi has asked me to come up with a presentation on cardiopulmonary resuscitation and update and post-resuscitation care. And for this, I would like to ask you at first, who knows how to resuscitate a patient? More or less everyone? No? Not everyone. So I brought with me something for every one of you. Even if you know what is resuscitation, you will hopefully benefit from this lecture. And if you don't know, you know it after the lecture, how to do cardiopulmonary resuscitation. It's about life and death in this session today. I'm not sure whether you know this guy. You know him? Football player. Soccer player. You have seen it in television when he was playing in the European Championship, and during the game he collapsed. So if the heart is not pumping blood and oxygen to the brain, people get the brain does not function anymore within 5 to 10 seconds. So you have seen it. He was just collapsing. Fortunately, he was resuscitated successfully by the medical team on the field. And already in the afternoon, he was again on Instagram. Like this, it could be every time. If people would react very fast and very early, you should not wait until the ambulance is coming, because the ambulance is always coming too late. Fortunately, many people have been around who knew how to resuscitate, and that was the reason why he was surviving. And he's again playing soccer in the Premier League in UK. I have some conflicts of interest, mostly driven by organizations where I'm working in an honorable position or in a board position. So what is most important with regard to resuscitation, it is just the heart is not functioning anymore, the brain is dying, and we need to pump blood to the brain with our hands. So our hands are doing what normally the heart is doing. And all that is needed to save a life is 2 hands. This is one of the most important slides I brought with me. If you have a collapse, like in the soccer player or so, the emergency medical service, the ambulance, is arriving in my country in the median, not at 7.5, but at 9 minutes, but sometimes very much later. The problem, however, is the brain can survive for 3 to 5 minutes only, and then it dies. So the ambulance is more or less, in almost all cases, coming too late. And there is a time window for lay resuscitation. The EMS will never arrive within 3 to 5 minutes, but lay people, bystanders, may be there and they can start. And if lay people start, we have 3 times more survivors with lay resuscitation, 3 times more survivors. Tripling survival with just 2 hands. You probably know, you have heard about the chain of survival. The chain of survival is the new chain of survival, which was based on real life data in United Kingdom. And you can see early recognition and call for help and early CPR is much more important than early defibrillation or post-resuscitation care. So what lay people are doing, it's much more important than what professional people are doing. Please keep this in your mind. We as doctors or as nurses or as paramedics only have a very low impact on survival. The most important impact is lay people. This has been shown in several studies. I brought with me one study from Denmark over 10 years. There was a national initiative to improve cardiac arrest management with rates of bystander intervention and patient survival after out-of-hospital cardiac arrest. They started with a bystander CPR rate of 20%, so only in 1 out of 5 cardiac arrest victims, a bystander started CPR, which was bad for the survival of the patients. And they made a lot of different activities to increase bystander CPR rate to bridge the time until the ambulance is arriving. And one of the key things they did, they introduced mandatory education in resuscitation in elementary school. So it was the law to educate school children in CPR. This should be the law, and that's my passion, this should be the law all over the world. And therefore, it's good that you are doing these Kids Save Lives activities here, because this, if it's going around the world, will save hundreds of thousands of lives worldwide. So they learn such a lot of things in school, and they just need to have 2 hours per year to learn how to do cardiopulmonary resuscitation. That's my passion. This increased bystander CPR rate, and as you can see here, survival following out-of-hospital cardiac arrest in these 10 years increased by 3-fold. 3-fold increase in survival in a deadly entity. We have some doctors in here and many medical students. Do you know any intervention in a deadly entity where survival was increased 3-fold within 10 years over the last 50 years? Do you know anything? Any intervention, any drug, any surgery, any? That is much better than anything we have in our hands in medicine. So we need the public to increase survival. If this would also happen in Germany, and we are very hard working on this, we would save 10,000 additional lives every year in Germany. In Brazil, you have 3 times more inhabitants. This is just an estimation, 30,000 additional lives per year, each year in Brazil. The only thing you need to educate the public is check, call, and compress. Check for signs of lives. Is there normal breathing or not? Call the emergency. The number here is 192. Okay, 192. I'm sure everyone in this room knows. And then compress and be the heart of the patient and pump the blood to the brain, and the patient will survive. This is also reflected in the chapters of the new ERC guidelines, and I brought you some examples from the guidelines with me today. And the most important chapter is probably System Saving Lives. I will come back to this. Epidemiology of cardiac arrest, out-of-hospital cardiac arrest in Europe. You can see the rate of bystander CPR, which is key. The average is 60%. It's better than in Germany. Range from 13 through 83%. What is the bystander CPR rate in Brazil? Do you know? What is your estimation?
I think 10%.
10%. Room to improve. Survival varies from 0 to 18%, in average 8%. So in average, less than 1 out of 10 out-of-hospital cardiac arrest patients survive. Although out-of-hospital sudden cardiac death is the 3rd leading cause of death in industrialized nations, the amount of deaths that we count in Germany following out-of-hospital cardiac arrest is close to the amount of all deaths by all cancers together. So it is a real healthcare issue. And we need to focus on that. So in Germany, bystander CPR rate is 40%, survival is around 11%. So in Europe, we have calculated this. We have 350,000 deaths per year by out-of-hospital cardiac arrest. So the ambulance is driving to the victim, but the victim does not survive. This is 1,000 deaths per day. This is the amount of the healthcare problem we are facing. This is as if 2 jumbo jets would crash down every day, all over the year, without any survivors. That is the amount of the healthcare problem we have. We are investing billions of dollars in research and treatment for cancer patients. And we should also start to invest in this entity because not very much more patients are dying out of cancer. For Brazil, I just an estimation, 175,000 deaths and maybe 500 deaths per day. You have around 40,000 deaths by traffic accidents. This is 4 or 5 times more a problem. We need to invest here. And it's easy. It is easy to improve survival in these patients, as you have seen in the soccer player. The most important message for today, 5 top messages, is system saving lives. These are the 5 things that are most important. You can see Kids Save Lives is 1 out of the 5. And I will go through this very briefly and very fast. And if you have, by the way, if you have any questions or comments, just, can you see? Or, yeah, okay. Just ask me. Number 1. Raise awareness about CPR and defibrillation. That's what we are doing today. That's what Kids Save Lives is doing. Because, you know, you remember that chain of survival, early recognition, and early CPR is much more important than anything we can do in the ambulance or in the hospital. That is also the reason why we have started the European and then a worldwide campaign on this. We have 3 times more survivors with lay resuscitation, and this is our worldwide initiative, the World Restart a Heart Initiative, with many, many, many organizations that I have convinced to participate, including the International Federation of the Red Cross. We are present with this initiative in 192 countries of the world. I didn't know how many countries we have in the world, but maybe you know. I have checked with Wikipedia. So we have, it is changing over time sometimes, but in Wikipedia, it says we have 194 countries in the world, and we are, with our initiative, we are in 192 countries. So we are a real worldwide initiative. And Naomi and her whole team and the anesthesiologists in Sao Paulo and in your country are joining. Thanks for joining World Restart a Heart. International Federation of the Red Cross is sending toolkits in 192 countries. That is really impressive. This was number 1. Number 2 is use technology to engage communities, which means so-called first responder systems. So if you have a smartphone, you can register at the dispatch center, and they know probably if there is a cardiac arrest outside in the corridor. The ambulance will take 10, 20 minutes until it arrives. But if the dispatch center knows that you have a mobile phone, which is, and you are here, then they can call you as a first responder. That is the second way, because then the victim gets help much earlier than if they have to wait until the ambulance is arriving. So first responder systems also can work through a pandemic here in Freiburg in Germany. In more than 50%, first responders reach the victim earlier than the ambulance. Implementation, rudimentary, room to improve. Next thing is Kids Save Lives. You know a little bit about this already due to the activities of Professor Naomi and all the others. This was the start of our national initiative in Germany. By the way, we always have good weather when we are doing something with children. So maybe we have some help from the sky, from heaven. We have 2 logos on Kids Save Lives. We have the support. I was visiting the World Health Organization in 2015 several times, and they support and recommend Kids Save Lives worldwide. So this is a great achievement, and I'm proud of it. In Europe, we have 6 countries where Kids Save Lives, where school children education in resuscitation is mandatory by law. We have another 24 countries where it is a suggestion. This is all upon our activities, so I'm proud of this. Our suggestions for kids is start in the kindergarten. They know how to check for signs of life. They know how to call the ambulance. When they are 10 to 12 years, they can also compress, and with 14 to 16 years, we teach them ventilation and automatic external defibrillators. Nevertheless, implementation is not good, so we can improve in Europe and in all other parts of the world. And this is Kids Save Lives Brazil, starting in 5 years ago, probably. Yes. 5 years ago. This is the logo of Kids Save Lives Brazil, and you can see it is always, the children are always absolute enthusiastic. So it is fantastic to see how high levels of altruism and engagement they have. They will never forget what they have learned. It will be like bicycling or swimming. They know what to do if a cardiac arrest victim is down. And now, wait a moment. I have brought with me a 4-year-old. That is an audio tape from a dispatch center in London. A 4-year-old called the dispatch center. Please listen to this. It is very touching. Even kindergarten children in the kindergarten can help. So please start. Yeah.
No, please, what is your emergency?
Hello, I'm Roman.
Can you hear?
Okay, where's your mummy?
She's at home.
And where are you?
At home as well.
Can you do me a favour? Can you go and get mummy?
She can't, she said.
You said mummy was there. What do you mean she said?
It means that she's closing her eyes and she's not breathing.
Right, so do you know where you live?
Road 22.
Can you go to your mummy and shake her for me?
She's not waking up.
Give her a good shake. Shout out, mummy.
Mummy! It didn't work.
Are you in Kenley?
Yes, Kenley.
What is your name?
Roman.
I would say no adult person would be as cool as this 4-year-old guy. Very adequate, very to the point. He took the iPhone of his dead mother, unlocked it with the fingerprint of the mother, and used Siri to call the EMS. 4 years old. We need to start in the kindergarten with this. Kids Save Lives is very important. We will publish in May an international collaboration with all the suggestions, including this chain of survival. And number 4 is cardiac arrest centers. Cardiac arrest centers are important because we started in Germany some years ago, 2 times more survivors with cardiac arrest centers, because most of the people having a cardiac arrest outside the hospital have it because of cardiac coronary occlusion and myocardial infarction. So they need to go to percutaneous coronary interventions as fast as possible. Since 2017, 6 years, we have criteria in Germany. We have 103 certified centers, including Switzerland and Austria. Implementation is not bad in Germany. We are the pioneers worldwide with cardiac arrest centers. In Europe, even the Americans are not as far as we are. In Europe, it's in progress. And number 5 is telephone CPR. Do you know what telephone CPR is?
To give you some assistance to do the CPR by lay people.
Yes. If a lay person is calling the dispatch center, The dispatcher says, please stay on the line. I will send you the ambulance and I will explain you now how to do cardiac compressions to the victim, because this will be associated with a tripling in survival. And then you can explain this within 1 minute. Do you have something like this in Brazil or in? It's very easy to implement. The number needed to treat is 7. So you need to do this 7 times to save 1 life. This is, again, much better than any drug or any surgery or any intervention we have. And you need to spend maybe 10 minutes. So with 70 minutes time invest, a dispatcher can save a life. That's much better than any professor or any doctor or any nurse can do. You probably remember what this is. Young people don't know what this is. They cannot use it anymore. Implementation is mixed. And this is an example. We have many examples, but this was on the title page. Lübeck is a small town. It's not so small, but a town in the north of Germany in January 2022. This 43-year-old person got an acute myocardial infarction. He collapsed at home. The 10-year-old Leon was there and the 7-year-old Mila. Leon called the EMS, the dispatch center. The dispatcher told him, please send your sister to the door so that the ambulance knows how to go in. And now, please, we will explain you now how you can do thoracic compressions on your father, that he will survive this cardiac arrest. It took the ambulance 10 minutes to go there. So he did cardiac compressions for 10 minutes. Oops. Sorry. And he survived in excellent conditions. It's important that we educate school children. They get a lot of gifts in the dispatch center thereafter. And this is, do you know what this is? The big 5, and what you have seen right now was the big 5 in resuscitation. The big 5 in resuscitation is much more important than any drug, than any device, than any post-resuscitation care. The big 5 are most important. We have published that in the European Journal of Anesthesiology. This is a summary: interventions, lay resuscitation, telephone CPR, first responder systems, cardiac arrest, associated with a 2 to 3-fold increase in survival. And the thing that we need for lay persons is check, call, compress. Please never forget, check, call, compress. Check for signs of life. Is he only sleeping or drunken, or has he or she a cardiac arrest? Very fast, 15 seconds, not more. Look for normal breathing or no breathing. Then call the emergency 192 in your country. And then start pumping blood to the brain, and that's all. If it takes, the EMS takes more than 10 minutes, then you probably should also ventilate. For the first minutes, there is enough oxygen in the heart, in the lung, in the legs, because only the brain is using such high levels of oxygen, but not the other parts of the body. So there is enough oxygen in the blood, you need to pump it only. Basic life support, I guess you all know, but not all. Some few said, no, I don't know how to do CPR. Start with thoracic compressions, and you cannot do anything wrong. If this person does not have a cardiac arrest, he or she will say, hey, please don't be so rude to me and stop pumping on my chest. There is no harm with it. So in doubt, always start cardiopulmonary resuscitation. Compression depth is it's like the smartphone's diameter, 5 to 6 centimeters, 100 through 120 per minute, so 2 times a second. So ha, 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 ha. That's the rhythm of staying alive also. Bee Gees or other songs. Do you have a song in Brazil that has the right? Can you sing it for me? It is my intention that every person in the world has a song in her or his mind that has the right rhythm, so that all people in case of emergency know what is the right rhythm. So please don't forget this. What is baby shark? That's the rhythm, 5 to 6 centimeters. That's all you need to do. And then the patient will survive. No interruptions. If you're not alone, change every 2 minutes because it is exhausting. We did it yesterday with strong school children. And already after 1 minute, they said, hey, I'm exhausted. So change every 1 or 2 minutes. That is helping if you're not alone. But the 10 years old Leon was alone and he did it for 10 minutes. Yeah. You can also use ventilation if it's this longer time until the EMS is coming, or if you have a patient who was drunken where there is no oxygen anymore, or in children, you always need to ventilate because they don't have cardiac problems, but ventilatory problems. You may also use an automatic external defibrillator, but don't run away. Most important thing is cardiac compressions. And only if there are enough people there, you can send someone for an automatic external defibrillator. So this is not most important. Most important is press hard and fast. That's all. Compression death is important. We have done CPR trainings with very strong boxing people, masters of boxing. They all use this kind of compression death, although they have the power. So because everyone is afraid of doing harm to a patient, but you cannot do harm. You need to press as much as you can, and in 50% you will broken ribs, but this does not harm the patient. This will heal if the patient is surviving. The most important thing is the blood flow. You need to generate blood flow, and therefore don't be shy. Survival to hospital admission is immediately associated with a compression death. So please compress as hard as you can. Check, call, compress. For those who are doing advanced life support, if you're in the hospital or coming with the ambulance or you have some things with you, intubate the patient when you are trained. In other cases, use back valve ventilation or supraglottic airway devices. Use capnography. In ventricular fibrillation, do 1 defibrillation. But of utmost importance, much more important than all this, is heart compressions without any interruptions. In adults, IV access, intraosseous is also used, but not as good as IV access. Use adrenaline every 3 to 5 minutes. In VF, following the third defibrillation, amiodarone or lidocaine can be used in VF. That's new in the new guidelines. This is our input to the world. We investigated thrombolysis. So if you have a pulmonary embolism as the underlying cause of deterioration, which is the case in 5 to 8%, then use a thrombolytic agent during ongoing CPR and do CPR for at least 60 or 90 minutes to give the thrombolytic agent the time to solve the emboli. So thrombolysis is recommended, as is lipid resuscitation in intoxication with local anesthetics. But again, of utmost importance is heart compressions. That is much more important than anything else. All that is needed is 2 hands. So we have reversible causes. This is in Germany, but I didn't find a similar picture in English. And please also think about ultrasound for differential diagnosis during ongoing cardiopulmonary resuscitation. ALS, advanced life support, the top messages are here. Press as hard as you can, use a defibrillator and look for causes of cardiac arrest. Cardiac arrest prevention, particularly in the hospital, but also in the out-of-hospital setting, is another major issue. And oxygenation, intubation or mask ventilation. Drugs, I already pointed out, adrenaline, amiodarone or lidocaine, and thrombolysis in pulmonary embolism. And you may also use eCPR or ECMO in selected cases. I will come back to you in a few minutes from now. We have the advanced life support algorithm. This is the European one. The American one is very similar. Intraosseous or intravenous. Intravenous is better. Identify and treat reversible causes. Don't forget them. And we have a huge chapter on special circumstances, but I don't have the time to go into this. But remember, in pulmonary embolism, or if there is high suspicion on pulmonary embolism, please use thrombolytic agents. Another very important topic is coronary angiography and percutaneous coronary intervention in cardiac arrest patients, okay, after return of spontaneous circulation. But this is in those who have no return of spontaneous circulation, who are coming in the hospital with ongoing cardiopulmonary resuscitation. As I said, in most of the cases, they have an occluded coronary artery, so they cannot be stabilized in the out-of-hospital setting. So the ambulance should bring them to the hospital with ongoing CPR. And as you can see here, 700 patients, 1 out of 4 did not have return of spontaneous circulation before admission. They had longer resuscitation times because they have transported with ongoing resuscitation to the hospital. They had similar rates of coronary occlusion. And look at this, the success rate of percutaneous coronary intervention was 90% in patients without stabilization during ongoing CPR in the cath lab, or in patients with return of spontaneous circulation. And survival was 24% in those transported during ongoing CPR to the hospital. So don't give up in the out-of-hospital setting if you have the feeling that an acute coronary occlusion is the underlying cause of deterioration. Transport them in the hospital. When they have successful PCI, the survival rate is already, in those without pre-hospital hemodynamic stabilization, 35%. And you may also use ECMO. This is one of the studies. They are not all as positive as this study I'm showing to you now, but this is very impressive from North America. They used ECMO in failed resuscitation in the emergency department, or they treated them with ongoing standard cardiopulmonary resuscitation. And as you can see here, survival to hospital discharge with ECMO was 40, number of patients with data. Survival to hospital discharge was 34% with ECMO and 7% without ECMO, with good neurological outcomes. So ECMO may be useful. This is the Kaplan-Meier curve for those having ECMO and for those not having ECMO. So a significant difference. So this is my summary for the period before post-resuscitation care. I will come to post-resuscitation care within the next 5 to 10 minutes. Everyone can and must save a life. Kids save lives is very important, of key importance. World Restarter Heart, telephone CPR, it's very easy to implement. So start in Sao Paulo or in Brazil, or first responder systems, good CPR and cardiac arrest centers, but we need the help of politicians. All this can only be established with the help of politicians. And we need to tell them, hey, with sudden cardiac arrest, the amount of deaths is close to the amount of deaths we have in all cancers together. They don't know. Even I didn't know that before I came to this topic. And please think about the big five. It's about 50,000 lives every year that we could save in addition in Brazil, and that's a lot, I think. Last not least, post-resuscitation care. Or are there any questions in the meantime or comments? Or thank you. Post-resuscitation care is only a very minor topic if it is about life and death, as you can see here from this chain of survival again. This is the infographics from our ERC guidelines, again with 5 top messages. Use ABC, airway, breathing, circulation. Don't use too much oxygen. An oxygen saturation of 94 through 98% is absolutely enough. Use probably PCI. You have seen already you can use it during ongoing CPR. Most of the patients have a coronary occlusion. Use temperature management, at least for 24 hours, 32 through 36 degrees Celsius. Avoid fever, because elevated temperature is, in all cases of neurotrauma or neuronal injury, is dangerous and associated with a worse outcome. Don't do prognostication within the first 3 days. So after 1 day, you cannot say whether the prognosis of a given patient is good or bad. Wait at least 3 days. In former days, we stopped therapy in many cases too early. And we have data suggesting that patients' treatment was stopped, although they would have had a good chance to survive. Rehabilitation is also another topic in these 5 top messages. We have very nice infographics in our European Resuscitation Council guidelines. You can download them from our websites. Prognostication, not within the first 72 hours. In case you're doing prognostication, use at least 2 of these markers and investigations to fix the neuronal prognosis. Do out-of-hospital cardiac arrest patients have increased chance of survival when transported to a cardiac resuscitation center? So not the next hospital, but take maybe 20 minutes, 30 minutes longer ride with the ambulance to a cardiac arrest center where they can do PCI 7 days a week and 24 hours a day, because this is associated with a 2-fold increase in survival. So please think about that in your future when you're treating such patients. Oxygen targets in comatose survivors. A very recent publication in the New England Journal some weeks ago, I would say, or some months ago. As you can see here, oxygen target around 68 to 75, or more liberal, around 100. No difference in all outcome variables, as you can also see here in the Kaplan-Meier curve. So you can even accept lower levels of oxygen. Same with blood pressure. Also a very recent publication out of the New England Journal. If you have a blood pressure of 77, a mean arterial blood pressure, which is compared in this study to 33 millimeters of mercury, again, no difference. So you can relax, use less oxygen and less mean arterial blood pressure. And my last point for today is hypothermia. Hypothermia is very, very, very good in protecting the brain. And that is the reason why we're using it in cardiac arrest patients during their recovery. And to illustrate this, I would like to come up with a case report. Winter in Cologne. In winter, we have -10, -15, sometimes -20 degrees. You don't know this in Sao Paulo. But in winter, then you have a lot of ice on the lake. Children like to play on the ice, but sometimes they go under ice. And this 6-year-old went under ice. His 2 friends were with him. They had a mobile phone. They called the EMS. Firefighters arrived 20 minutes later. It was a little bit up road in the forest. Water rescue 5 minutes later. Time in icy water, around half an hour. Any chance to survive? Without oxygen? Half an hour, icy water. What do you say, Naomi?
Only child. Only child.
Only child? Well, he arrived. Oh God, what's going on with this? Sorry for this. Okay, he arrived with ongoing CPR. So the emergency physician put him out of the water, started with CPR. 1 hour after drowning, arriving in my hospital, Glasgow Coma Scale 3, white pupils. This is the temperature, asystole. We did another CPR for another 1.5 minutes. We put him on ECMO for 3 days. And don't warm him until normal temperature, but until 34 degrees Celsius. So we treated him further with therapeutic hypothermia. And 2 days later, we let him wake up and extubated the trachea. The parents were with us in the room when he woke up. We all didn't know what happened. And he opened his eyes and said, "Can I please have a piece of bread with Nutella?" Some of my colleagues said then he must have brain damage if he's asking for Nutella. But that was so touching, you cannot imagine, for all of us. And he is now every day in the year when he was under ice and we resuscitated him, he is what is the right English word? He's doing his second birthday, and he invited the paramedics and the emergency medical doctors to his second birthday, and he's totally okay. So hypothermia is effective. That is the reason why I'm showing that. Pardon?
Glasgow 3.
Yeah.
And for 3 days at 34 degrees.
Temperature 23 degrees on arriving. Hypothermia is maximum neuroprotective. We don't have anything else in our hands that is so neuroprotective. Why is that so? This is a simplified model of what's going on after ischemia and reperfusion. Very simplified. You can see we have many pathways. And the good thing is we can relax because hypothermia is affecting all these pathways in a positive direction. And by the way, these animals and maybe also other animals use this in nature. Do you have these animals in your country? Murmeltiere, we call them. In the Alps, we have this. They sleep in winter time. So the heart is beating every 5 minutes for one time or so. They use all these mechanisms, and we can learn from nature, I would say. Target temperature management for cardiac arrest with non-shockable rhythm, cooling down patients for 33 degrees instead of having them normothermic. Doubling in survival, a very recent study 3 years ago. Again, you can see here, doubling in survival in non-shockable rhythm. In shockable rhythm, the Princess trial some years ago investigated close to 700 patients. They started cooling with a nasal cannula and 𝗪𝗏𝗏, which is like in the refrigerator infusion into the nasal cavities, which makes the brain very fast and very easily cool down already immediately after start of cardiopulmonary resuscitation. So they started very early. Also, the control group was treated with hypothermia in the hospital, but not in the out-of-hospital setting. And you can see the intervention in the subgroup of patients with ventricular fibrillation was very good. 1 out of 3 had a good cerebral performance category of 1 after an out-of-hospital cardiac arrest. Median time to cooling was probably also associated. So it's kind of dose response curve here. Time to cooling, the earlier the cooling started, the better was the neurological outcome, which is very clear to me, like in the child. If you start after 7 hours, it's too late. You need to start immediately. We are always cooling for at least 24 hours. We are cooling as soon as possible, and we start cooling as soon as possible. This is important. And as I already pointed out, International Liaison Committee on Resuscitation and European Resuscitation Council, we are recommending this. There was some discussion after that study that have been published about 2 years ago in the New England Journal. They compared hypothermia versus normothermia in 1,800 and something patients. But this study has also received high levels of criticism because they investigated patients that are at least not my patients and maybe also not your patients, because they had a bystander witnessed arrest from more than 90%. Bystander performed CPR 80%. Naomi told us 10% probably estimated in. So this is also not your patients. First monitored rhythm, shockable rhythm, more than 70%. In my country, it's 20%. So they excluded a lot of patients. So they only enrolled the very good patients. And if you have a bystander CPR rate of 80%, if someone is starting immediately CPR, that's like in the soccer player, you don't have any neurological deficit at all if you are lucky. So you probably cannot benefit from hypothermia. So therefore, there's a question mark here. And they reached the target temperature of 33 degrees 7 hours after randomization, and it took them 2 hours until they started randomization. So about 9 hours after the event, they reached the target temperature, which is far too late. Think about the 6-year-old. If you do it immediately, it's okay, but that was too late. Therefore, they didn't find a difference, but ischemia before start of CPR was in median 1 minute, because most of them had immediate start of CPR by bystanders. Target temperature was reached more than 7 hours after cardiac arrest, and they had high levels of lay CPR and shockable rhythm. So this is not our patients, and there is no therapeutic window where hypothermia can work after 7 hours after cardiac arrest. We have a lot of animal studies showing that hypothermia is working after cardiac arrest, but we have not one single animal study showing that hypothermia is working if you install it 7 hours after cardiac arrest. So you need to install it very early. So these are not our patients. There's still a question mark. We have investigated and published that some months ago. The effectiveness of target temperature management following cardiac arrest may depend on bystander cardiopulmonary resuscitation rates. So if you have bystander CPR rates, like in the trial that I have showed you right now, 80%, there is no absolute benefit with temperature management at all. But if you have bystander CPR rates, what did you say, 10%? We have 40%. Then you have a huge effect of hypothermia. This also fits very well to my pathophysiological thinking. So if you have some damage, you don't have such high levels of damage if you have immediate CPR. But if you need to wait until the EMS is arriving, or if you have lower bystander CPR rates, there's a huge effect on temperature management. These are our patients, these are your patients, and therefore hypothermia helps. This guy didn't need therapeutic hypothermia because he received immediate bystander CPR. And this fits very well to that study, stratified by the severity of encephalopathy. So is there an effect of temperature management or not? If you have mild encephalopathy, this is probably the soccer player, there is no difference between cooling or not cooling. If you have very severe encephalopathy, there is also no difference. But if you have moderate encephalopathy, there is a difference. It makes a difference whether you treat the patients with therapeutic hypothermia or not. This is a statistical analysis on that. Mild encephalopathy, no effect. That's our soccer player. Moderate encephalopathy, significant effect, favors 33 degrees Celsius for at least 24 hours. Severe encephalopathy does not make a difference at all. And we take 33 degrees for at least 24 hours as soon as possible. This is a meta-analysis from last year showing that cooling is effective from 𝗖𝗿𝗍 in Vienna. And this statement, I have it already in my bag. Hypothermia for neuroprotection in adults after cardiac arrest is in press. It's a Cochrane review from Yasmin Arish. Will be published in a few days from now, supporting the use of hypothermia following out-of-hospital cardiac arrest. So, but this is the most important thing, the big five. We are cooling 24 hours.
It only takes 2 hands to save life.
And this is my final message for you.
It only takes 2 hands to save a life. It only takes 2 hands to save a life.
Thank you very much. I'm not sure whether you have questions or comments or...
Perguntas, comentários. Pessoal, o professor Bennett é super bacana, uma pessoa super acessível. Pergunte alguma coisa. É a Sociedade Internacional de Resuscitação Cardiopulmonar, tanto pré-hospitalar quanto intra-hospitalar. Assim, ele trouxe uma informação nova, né, para a gente que trabalha no pré-hospitalar, mas o uso da hipotermia, 32 a 36 graus, imediatamente após a parada cardíaca, né, imediatamente após a PCR, é uma coisa super importante. Como nós podemos também aqui no Brasil desenvolver um telefone que possa dar essa informação que a gente dá para todo mundo, de como proceder a receber uma pessoa com parada, né? Então, tem uns aplicativos, até recebi um, vou passar para vocês, para a gente começar a usar e ver o que dá, né? Mas façam perguntas aí, o que vocês acham? E... Parece que você tem uma pergunta.
Não, vi só.
Então, e alguém?
Não, pergunta, mais um comentário. Tem alguns anos que uma vizinha minha morreu na minha frente, assim. E eu não sabia o que fazer, eu não tinha entrado na faculdade ainda, era totalmente leiga, não fui ainda mais, porque eu não faço medicina, faço obstetrícia. E lá, esse não é o foco, né? Então, quando aconteceu, foi, nossa, muito impactante, assim, pra mim. Meu Deus, eu vi uma pessoa morrer na minha frente e eu queria ter tido uma oportunidade de ajudar. A gente chamou a ambulância, mas isso em Belo Horizonte, né? Que é a minha cidade natal. A gente chamou a ambulância e a ambulância falou simplesmente assim, não tem carro disponível, a gente não vai. E para levar ela para o hospital foi um custo, assim, mas ela já estava pronta quando a gente levou, né? Na verdade, meu pai e minha mãe, eu fiquei lá no prédio mesmo. Mas mobilizou todos os vizinhos, assim, sabe? E foi muito chocante, assim. Na hora eu falei, meu Deus, complicado.
Quer falar, Milena, professor?
Yes,
Bem
I was just saying that a few years ago when I was not in school yet, like, I was a totally lay person and I didn't know anything about what to do in this kind of situation, and a neighbor of mine just died in front of me. We were all like together just trying to call an ambulance to get her some help and stuff, but they just said like, there are not enough cars, we're not going. So we had to take her on our own, and it was really hard to move her from the stairs where she fell to the car. And by the time my father and my mom could do that, she was already dead. So it was very traumatic. Like, she died literally in the staircase of our building. And every neighbor was pretty shocked after that.
How old was she?
She was around 70.
Okay. Yeah.
But I think it really would have helped to know this, like, back then.
You should, everyone in the world should learn this in school. That's my passion and my goal. Then this would not happen like this. Maybe she would nevertheless die. We cannot save all patients, but it is important that everyone who is in such a situation knows what to do. Because if you are in such a situation and you can do something, you have a much better feeling thereafter. Like the 10 years Leon, he is totally proud that without this guy, his father would be dead. So he is totally proud that he was successful. So thank you very much for this comment.
I think like it would have been enough time if I had known this back. It would have been enough time to do something, because from the moment she screamed like so much pain and she fell in the stairs until the moment she was like with totally blank eyes and I knew she was dead. There was enough time to do something, but the ambulance wouldn't go still.
And this was here in this city, Sao Paulo? Or?
Belo Horizonte.
Belo Horizonte, yeah, okay. It's close to Rio.
Yes.
Yeah, I've seen it on the map, yeah. Thank you. So all that is needed is 2 hands.
I do have a comment, but just a comment. You were telling about this new thing. New for me. I don't know if it's new for everyone. Naomi also said about the hypothermia treatment. Not treatment, but this technique, I think, yeah, because it protects the brain. And I didn't know that this actually was possible. When you were presenting the case of the child, I was thinking that like he's dead because half an hour underwater, not just water, but really cold water without breathing and everything. So probably this kid was already dead, and it was almost right. And with that particular situation, like it was an accident, but immediately the child had this treatment because of the place where he was. So I don't know if it was the first case that triggered the people to start studying this as a treatment. And now I have a question. So there in Europe, is it something that is actually used to treat patients that have a cardiac arrest, or is something that some physicians do, some do not, or everybody does? How does it work?
In Germany, 70% of all hospitals are using this type of intervention, but it differs. In UK, it's maybe 30 or 40%. Because they don't believe. They believe in this last study that I have showed you, but as I have explained, we have a lot of criticism for that study. Pardon?
A lot of flaws.
Yeah. So, and I can also tell you that when this child, 6-year-old, reached our hospital and we wanted to put him on ECMO, but this is a secret, it should stay in this room. We called our cardiac surgeons and told them, please put him on ECMO. And they said, pH 6.6, lactate levels, I don't know, 30 or so, temperature 23 degrees Celsius, no way to survive, we will not do it. And I insisted and I said, you must. And then they put him on ECMO and he survived. Some weeks later, they had a big article in the newspaper in Cologne saying, cardiac surgeons help to survive a 6-year-old boy. But he survived, and that's the most important thing. Pardon?
Today we had some basic life support for medical students of the first year. I can tell you something about this. Vocês podem dizer alguma coisa sobre o que vocês aprenderam hoje?
It was really fun because we only have biochemistry classes, so it was first time we put the medical gloves and did something.
Yeah.
Did you like it?
Yeah.
Did you enjoy it? Did you learn something?
Yeah.
Naomi wants some positive feedback.
Yes, sure.
Someone
Collapse?
Yeah,
You may say it.
I know a little what to do and
I can thank you very much for this. I can tell you we have a project with our students, our medical students. We have asked our medical students whether they would like to help us in educating school children. And we have a program in our medical faculty where students, medical students, are going to different schools in Cologne without us, only the students, and educate school children in cardiopulmonary resuscitation. And the school children accept medical students much more than old professors, because you are more or less in the same age as they are. And the medical students are totally enthusiastic about this project. And maybe you can think about, or maybe you have already thought about that.
I think that all students of the university can do. Not only medical, not health professional students.
That's even better.
Yeah.
Yeah. And also we have a program in Germany to educate school teachers, because we have investigated that, and it is scientifically very clear that doctors or nurses are not better than educated school teachers to educate school children in cardiopulmonary resuscitation. So teachers can do it as good as doctors. Therefore, I would guess that students out of the medical field can also do it if they have been trained before by medical professionals.
How often do you think it would be great for no health professional to do the CPR training? Because I'm not in the health area, I'm a journalist.
Mm-hmm.
And for example, if I know how, if I do the practice CPR training today, how often, like 6 months, a year,
So,
be great.
so your question is how often you should be trained? Our thinking is that you should be trained for at least 2 hours, maybe 4 hours, but 2 hours is enough once. And then the scientific literature differs, whether you should have a very brief refresher after 1 year, but a brief refresher is enough, or after half a year or after 3 years. So it is not clear right now. What is clear is that you need a initial education, 2 hours, maybe 4 hours at the beginning, and then brief refreshers. But these brief refreshers can also be done by yourself with the help of the internet or so. I can tell you, when we are going to schools in Germany, the ministers always said, oh, this is so expensive and we need the mannequins that you have used in your training, probably CPR mannequins. And what I'm telling them then is we have very, very, yes, we have very low cost mannequins. For example, such a bottle of water, you remember the big bottles, 1.5 liters. If you put the water out, put the cup again on it so that the air is in, and then you put an old t-shirt over it, and then you can probably use newspapers to stuff the t-shirt, and you can use a melon as the head, and then you have a low-cost mannequin that costs nothing, and you can use this all over the world to train everyone in CPR. You don't need to invest so much money. So if we would invest only a very small portion of what we invest in traffic safety or cancer treatment or research, we would be able to save hundreds of thousands of lives worldwide every year. And that's my passion.
It's our passion now.
Thanks for this support and great enthusiasm.
What do you think?
And I said, when we are discussing this, we always have good weather.
Yeah.
Thank you so very much. All the best. Stay safe and happy. Thanks.